Dear ladies and gentlemen, welcome. We would like to speak about peripheral vessel occlusion, how to treat them.
Welcome also from my side. Peripheral vessel occlusion is a huge topic for 20 minutes of time. We try to narrow the topic in form of answering the question why to treat, how to treat, and if we come to that point, if to treat, why to treat, how you treat.
So now we would like to present 4 cases to start with. Also, we show their MR perfusion and diffusion images and their clinical aspects. So the first case was an 83-year-old patient, which was first seen sick 1.5 hours before admission. It showed NHSS score of 4 on admission with aphasia, dysarthria, and paresis. The second case is a 17-year-old patient which woke up with a stroke. On admission, NHSS score was 10. Then the third case is another 85-year-old patient which was last seen well 7 hours before admission. It presented with an NHSS score of 4 because of aphasia and dysarthria. Then the fourth patient was a 20-year-old patient which woke up with a stroke. On admission, NHSS score was 2 because of speech problems and paresis. As you might have noted, all of those patients showed a left-sided middle cerebral artery territory stroke with a mismatch. They differed in age, time delay from symptom onset, and in their NHSS score. So please have a think how you would have treated those patients. We will tell you later in the talk how we treated those patients finally.
Some more facts and information. Why is it so difficult to talk about? First of all, the definition. What is a distal occlusion? In our terms of understanding, distal occlusion is any segment of the ACA, the PCA, or at beyond the Sylvian point, M3 opercular segment. However, even an M2 branch can be very small in size and can be called so-called distal occlusion. It depends. Studies in the literature evaluate medium to large vessel occlusion mainly. Most of the studies mention distal thrombectomy, but including patients above NIHSS from 10 points, and these are clinically functional M1 occlusions, so not really a peripheral vessel occlusion. Important, also the tissue area compromised in distal occlusion might be very relatively small. It can still be devastating for the patient due to eloquent areas, means the vessel and the area can be small, but the disabling fact for the patient is that what matters or counts. There is one important, not really a study, it's more a review, which we want to recommend. It's the one from SAVOR called Thrombectomy for Distal Medium Vessel Occlusion, which gives really a nicely overview about this topic and also explains very nicely which branch of which vessel does which symptoms. So you can learn about those 34 arterial branches and their syndromes. A clinical syndrome is always heterogeneous, fractionated, and frequently disabling. There is not really a randomized trial about this topic. We have one larger series of patients, which is called Beyond Large Vessel Occlusion and was published in 2018 by Grossberg. They took all those distal vessel occlusions together, and they found not only a good point, they also found a mortality of 20%. They did find an improvement of MRS from 30% of the patients, and in 7% of the patients, they found a hemorrhage, an intracranial hematoma, caused by the thrombectomy of the distal vessel occlusion. And I showed here on the right-hand side just a few examples for that. you see that you can see leakage due to perforation. And here you can see a hematoma as well. Sometimes you have to occlude the vessel in order to treat the perforation and not to worsening the patient. Another fact is that you always have to take into account that a distal occlusion can be both, can be isolated, so happen through an emboli from the heart or wherever, and it can be a residual distal occlusion after a proximal vessel occlusion. You not always knowing if the thrombus was fragmented from beginning, or if you yourself did it via treating the patient. Another important point is that not every symptom is really good shown in the NIH score. You can have 1 point with a hemiparesis, a weak hemiparesis, or you can have 1 point with an aphasia, which is for the patient a different cup of tea, really. One is disabling and eloquent, and the other can have a normal life, more or less. So if you want to treat the patient, your benefit need to outweigh the natural history. So ask yourself, what would happen if you don't treat the patient? And the potential harm. Are you technical, feasible? Are you able to do it in your department? The thing about thrombus fragmentation was analyzed in 2015 via MRI. You cannot know if you fragmented the thrombus or if it was fragmented before, unless you do an MRI or you have susceptibility weighted images before you treat the patient. So they looked at it and they found only in 7% of the treated patient that the thrombus was fragmented from beginning. And in the other, over 90%, the thrombus was single. That means that if you have more than 7, 8, 9% of thrombus fragmentation and distal occlusion while you do a thrombectomy, it might be your technique yourself which caused the fragmented thrombus. So it's more rare that a thrombus is fragmented from beginning than that this happens during the procedure. Anyhow, if the thrombus is fragmented from beginning, these patients tend to have a worse outcome. And this is also an interesting point. If the outcome is worse from beginning, then you should know what to risk and what not to risk. We and many others could show anyhow an open vessel is better than a closed vessel. So a TP3 result in thrombectomy gives after 3 months 66% a functional independent life, which is a very important result. Compared to 46% of patients with a TP2B result. So you could not open all vessels. This was done by Kersmacher and Graller in 2018, but also the Hermes studies, the Hermes results showed that pooled analysis. So it's not something new, it's just something to stress.
So now we would like to stress, since the 90s, we have intravenous thrombolysis available. Since 2015, EVT is evidence-based. But what about the future? So will we add urokinase in future intraarterially in some patients? This is the question we would like to ask.
When you do thrombectomy, even distally or proximally, we always talking about stent retriever as well as aspiration. There is not a technique superior to each other. I personally have more experience with stent retrievers and with aspiration, but my colleagues tend to do both. It's just an example for both techniques here. With stent retrievers, technical point is that there are smaller and more flexible devices now and since 2 or 3 years available for smaller vessels. They are designed for smaller vessels. For example, the Catch Mini stent retriever or the Tiger 13 stent retriever, both function well, function really nicely. And we also have microcatheters with a length which can reach those distal occlusions. So it's not longer a matter if you can reach them technically, it's more a matter if you should do it or not. It's not technical thing of that it's difficult or something. You can also use a technique which we call semi-deployed stent retriever technique. Semi-deployed stent retriever means that you don't open it completely. You don't use it completely. You may just use 1/3 or half of it and capture the thrombus inside. So think about your vessel diameter and the diameter of the stent retriever if you do it. We also recommend the use of an intermediate catheter if you do it, which gives you the opportunity to do distal aspiration, for example, with a 3-max, Catalyst 5, Sophia 6F, or even the React 68. It's a really nice catheter to do it. This distal aspiration protects side branches and unaffected vessels, especially in isolated distal occlusions. So we call it, if you play ping pong with a thrombus, it's not always a good thing to do, right? You should try to get it out in one go and not even playing ping pong with it. The mini pinning technique is also called mini pinching technique or pinching technique. That just means that you grip the thrombus inside. So you take the thrombus inside of it and then you grip it. You really tight it fasten to your microcatheter.
So let's look at the recent Bernie studies, which fit perfectly into this talk. So the first one addressed best therapy in patients with low NHS score and with occlusion of the M2 segment of the middle cerebral artery. The second one addressed urokinase. So let's start with the first study. Here is the background. Therapy modality in patients with acute occlusion of the M2 segment of the middle cerebral artery and mild neurological deficits is still a matter of debate and data scarce. In this study, we consecutively included patients which were intravenous thrombolysis eligible. They were admitted to the Bernie Stroke Center between January 2005 to January 2020 with an acute occlusion of the M2 segment of the middle cerebral artery and a low NHS score on admission. We defined Ibt eligibility as follows. So time lapse was allowed until 4.5 hours from symptom onset. Or in case of an unknown time of symptom onset, we included patients if there was a mismatch in diffusion-weighted MR imaging and T2-weighted and or flare imaging with no clear hyperintensity in latter two sequences, or if no area of hypoattenuation in CT imaging was seen. Also, we were considering possible contraindications in accordance with current institutional and international guidelines. We defined 3 therapy groups. The IVT group, in which only patients which got treated by IVT were included. Then we defined the mechanical thrombectomy group, and finally, the EVT group. In the EVT group, we included patients which got treated by endovascular therapy, including intraarterial thrombolysis and or mechanical thrombectomy plus minus intravenous thrombolysis. We compared the IVT with the EVT group and the IVT group with the mechanical thrombectomy group. We defined primary outcome as favorable functional outcome at 3 months. Then we also looked at secondary outcomes as follows. So we looked at excellent functional outcome and survival at 3 months. And also we looked at successful reperfusion and symptomatic intracellular hemorrhage rates. We compared baseline characteristics and outcome analyses. I will not mention the details of the statistical analysis now. So here we are coming to the results. Age, sex, vascular risk factors, event etiology, admission NHS score, and independency before event were similar in group comparisons. However, in the EVT and mechanical thrombectomy group, patients significantly more frequently showed an unknown time of symptom onset, a longer time delay from admission to first treatment, fluctuating or worsening symptoms before admission, and more frequently showed a truncus superior as the location of acute vessel occlusion. Now we are coming to the outcome results. Here we see the modified ranking scale at 3 months. So as we can see, most patients survived. Also, many patients showed a favorable outcome, but also many an excellent outcome. There was no difference in group comparisons. Then here we see the modified ranking shift at 3 months. So only few patients showed low scores at 3 months. And again, there was no difference in group comparisons. Here we see the NHSS score shift at 3 months compared to baseline. As you can see, most patients showed a decrease of their NHSS score until 3 months, and only few an increase or a stable score. Again, there was no difference in group comparisons. And here we see the results concerning successful reperfusion and symptomatic intracellular hemorrhage rates. Only few patients showed a symptomatic intracellular hemorrhage, and the rates of successful reperfusion were moderate to high. Now we are coming to the limitations of this study. So it was a retrospective and monocentric study, and we have included only few patients. There was an imbalance of baseline variables, which potentially couldn't be adjusted for completely with regression analysis. Also, clinical presentation at admission represented a potential selection bias, potentially influenced the treatment decision, and contributed to the imbalance of baseline characteristics among the therapy groups. Also, we have included patients over a long period of time, over which treatment strategies and devices have evolved. Now we are coming to the conclusions. So our study found similar effectiveness of IVT only and EVT, and of IVT only and mechanical thrombectomy only in the analyzed patient group. So irrespectively of the type of treatment, we must be guided by the principle primum non nocere, which is notably important in this patient group, as we think. The natural course in peripheral occlusions has been shown to be favorable in short and medium term in many patients. However, there is little room to demonstrate a benefit for any therapy, really. We conclude that there is an unmet need for randomized controlled trials in this specific stroke field.
Let me just say one thing again to the last study. I go back, sorry for that. It's really a nice trial, therefore, because the patient group is absolutely homogeneous. This is something really difficult to find because they are so different all in all. Another Bernese study is the one from Kersmacher again. And this is belonging not to a patient selection or a decision-making thing. It is about those patients who failed or underwent unsuccessful or incomplete mechanical thrombectomy in anterior circulation large vessel occlusions. And here you could see that intraarterial used urokinase was not associated with an increased risk of symptomatic intracranial hemorrhage or 90-day mortality, which is an important point. Or some do fear if they use urokinase intraarterially that it will come to more hemorrhage. This is not the case. And we could get a 64% higher reperfusion, and therefore a 34% had an improvement in TICI grade. And as you learned before, if you improve the TICI grade, you normally also improve the outcome. Here's just a picture example. I just found that we not saw enough angiograms. So there's a TICI-2B after thrombectomy, and here you see that there is a vessel missing, and also in the parenchyma phase there is a parenchyma deficit in the central region, so quite an eloquent region. And after ER thrombolytics, after the application of it, this vessel did show again up, and we could see a nicely reperfusion in this area. So the higher rates of independence we saw if we did use urokinase intraarterially after failed thrombectomy or unsuccessful thrombectomy. And this was shown for TICI and for the MRI score. From the statistic way, we did find this for patients with a really bad TICI score before and after.
So now we come back to our cases. So you can see how we treated them finally. The first patient received intravenous thrombolysis only. The second one, mechanical thrombectomy additionally.
The second one indeed was a quite interesting case for us. It was not the first, but I think the second or third COVID-associated stroke. It was a 17-year-old boy, which is rare from itself. And we could open the vessel with mechanical thrombectomy with a normal catch mini. It was highly eloquent because he had an NIH from 10, he had an hemiparesis before, and the MRI after showed that we could nearly undo what happened. We also did chemical hematological investigations on it, and he had shown a relative ADAMTS13 deficiency. And I want just use that really moment to recommend, if you have a COVID-associated stroke, look for those factors. Look for ADAMTS13 and von Willebrand factor on the other hand.
So then we see here case 3 and 4. The third case we also treated with intravenous thrombolysis and mechanical thrombectomy, and the fourth one with IVT. So why did we treat those patients as we treated them? Let's see on the next slide how our flowchart is. So this flowchart helps us in decision making. In case there is an isolated distal vessel occlusion, an occlusion of the ACA, the PCA, the distal M2 or M3 segment of the middle cerebral artery, we check whether there is a potentially disabling clinical deficit present. If not, we might treat the patient with IVT or conservatively. However, if a potentially disabling clinical deficit is present, we tend to perform an IVT. And in case of an endovascularly reachable branch, we tend to add a mechanical thrombectomy with application of a stent retriever with an aspiration or a combination of both. However, if the reperfusion fails, we consider adding urokinase additionally. What isn't shown in this flowchart is also that we consider the imaging findings.
The next slide now focus again on another patient group. This is the patient group where you have a residual distal occlusion or distal emboli after proximal occlusion of the ACA, the PCA, or the distal M2, M3 branches. If this branch is still eloquent or in an eloquent region with potential new additional disabling clinical deficit, so aphasia, neglect, distal paresis or something like that, yes, then you again ask yourself if this branch is reasonable for mechanical thrombectomy. If yes, you go for it with either a stent retriever, aspiration, or combination of both. If no, you can use here intraarterially urokinase if you want, or if you failed the pass, then you still can do intraarterial urokinase. At that point, we tend, in Bern at least, we tend to talk to each other. So we tend to call the neurologist. We tend to ask about the clinic again, about what would you do? And we discuss that case. It's not something one single person is answering or deciding. That was all from us. Thank you a lot. I hope next time you can come and next time you can enjoy the snow, which is really beautiful around here.